Good evening, sir. Good evening, sir.
Good evening, sir. You can start, sir.
Thank you, sir. So today the class is on evidence-based management of unknown poisoning. So I'm not supporting any pharma company here. As you well know, this is our country with various states. So each one of the state has an unique poison. So the toxicology is geographically dependent. So what we are seeing in Tamil Nadu is not true in Himachal Pradesh, or what we are seeing in Rajasthan is not same in Assam. So the toxicology pattern, the availability of drugs, everything is vary. So today's agenda is how to approach an unknown poison in the emergency room. What are the challenges? A few untold stories and to sum up today. So if you read any textbooks, all the textbooks are like Western textbooks. They have a Western approach where they don't have much importance towards the history. They do some clinical examination. They dependent more on the laboratory work, that is toxicology screen. So any patient comes to the emergency room with any altered sensorium, they will do a toxicology screen and they will try to find out what are the toxicology things are there or not. Whereas when we move into the Indian approach, here the predominantly we see on history, some part of clinical examination, and the toxic screen is very, very less in our country because we don't have enough facility. If you want to estimate a paracetamol level in the patient's body, you are taking the blood and sending to the laboratory, you will get at least a week to get the result. So we don't have a much toxicology screening laboratory or there. Now the scenario is slowly changing. Now we are coming with the point of care test. I'll come there. So before starting this, I just want to give a scenario. This is a 17-year-old boy was brought to the emergency room in an altered sensorium with an unstable vitals. He was apparently normal few hours ago as per the informant. The clinical examination and basic lab investigation did not give any clue to the diagnosis. What do you think? What do you think? Any guess? So, whenever you are in a doubt, please think poison as one of your differential diagnoses, especially when there is an altered level of consciousness, sudden change, and unexplained vital signs that doesn't fit into any of your clinical judgment, and then you suspect poison as one of your DD. So, a lot of postgraduates are here, so I just want to ask few questions before I'm going in. As per Kamlesh Tiwari sir's request, we start with some MCQ. Okay. What are the indications for intubation in a poison patient, except obstructed airway, laryngeal edema, bronchoria, or GCS less than 9? Please answer. GCS more than 9.
GCS more than 9. Yeah.
Excellent. Excellent. So what is the antidote for iron poison?
Desperazone.
Yes?
Yes, desferoxamine.
Desferoxamide.
Excellent. We are now seeing lot of iron poison, especially in the child who the mother is pregnant. We are getting lot of iron overdose in the pediatric age group because the iron which is being supplied looks like a Gem's coffee. So it creates a lot of interest to the kids to taste what is that. So it is a desferoxamine. What is the dose of insulin infusion in calcium channel blocker overdose? Any guess? So it is 0.5
Yes, sir.
to 1 unit per kg. Okay. So this will be very useful in calcium channel blocker.
Due to network of Dr. Santul Kumaran, he has joined very soon.
Am I able to see?
Yes, sir.
Yes, sir.
Yeah, it is. See, clear lungs. Good. Theophylline toxicity causes hypercalcemia, hypocalcemia, hyperkalemia, or hyperphosphatemia. Any idea? It is one of the commonest cause. Especially we see a lot of patients in the winter season. It's a hypercalcemia. Your ECG classically will tell you the findings. So with this background, we move on to today's class. You may surprise why we are giving more importance to this poisoning. So these are the various things. Now even in the Netflix, the Korean cyanide, it's one of the famous Jolly and Joseph case, or the South Korean lung disease outbreak, and where they were found out that this was due to the exposure to the toxicity, pulmonary toxicity. So this mimics like a outbreak of lung disease. We have seen like a lot of pandemics. So if you see, this is a lot of papers and lot of print media were describing about the day in, day out, at least 1 or 2 cases in our area where they were exposed to this kind of poisoning. This may be a pharmaceutical agent, or this may be a pesticide, or this may be a plant. So this is a burden. I'm not going in detail. Though the toxicology is a neglected field in India, both as well as in the clinical practice as well as research, because no research has been backed up by the pharma companies. So it has not been flourished in the research arena. But very commonly we are seeing, and we are seeing a lot of person has their own protocol. There is no standardized protocol. We see many times when the patients have been taken some kind of poisoning also, they will be given atropine and then sent to a higher center, saying that it may act some time. Okay, this creates a lot of problems and confusing the treating physician what is the exact cause of poisoning and then the availability. So this is one of the paper from the North India, okay, saying that how this poison is been causing a lot of problems. Okay, almost 2 millions of life and 5 million were been disabled over a period of time. They have been disabled, and then Madam, you are net வந்துருக்காங்க. Am I audible, sir?
Yes, sir. You're audible.
Yes, sir.
Okay, thank you. So this is a paper where it has been examined around 417 patients, and they found that almost OPC aluminum phosphates are dominating the list in the top. And this is one of the worrying paper which has been right as an editorial in Indians time, saying that suicide is increasing, especially in the homemakers and the professionals, especially in the IT segment. This is a paper from the Kerala, which is considered to be one of the highest educational area where they are finding lot of people from the professionals are succumb to suicide. So this is not only a problem in India, it is also in the developing countries, neighboring countries. We used to see a lot of patients from the other countries also. So here we need a multidisciplinary approach. We are going to see how we are going to approach this patient. Okay. As we well know, any emergency patients we will approach in a systematic way, and in a poisoning patient we will do an appropriate decontamination technique, and timely administration of this antidote will definitely help the patient out. So today's objective is to recognize and manage the poison overdose by their clinical features, that is a toxidrome, understand what are the principles and the methods of decontamination or certain enhanced elimination way, and other principles and practice of the clinical toxicology. So before going in detail, what is a poison? So the poison may be any substance which is introduced into the living body, or death by its local or systemic action, or both, or when it become in contact with any part of that will produce the ill effect. This is called poison. But according to the father of modern toxicology, Paracelsus, says that all things are poisoning and nothing is without a poison. It is just only the dose that makes the thing not a poison. So anything can be a poison. One drug may be useful for one patient, another may be a poison for other patient. So here the dose plays very important role. So we have a systematic approach how to approach this poison patient. So any patient comes to the emergency room, we do an immediate assessment and stabilization, decontamination. If possible, we'll think of elimination of any enhanced toxin, antidote if it is available. We will do that, do a lab assessment, and then we'll do a deposition whether the patient is admitted in the ICU or the patient is observed in the emergency room or can be safely discharged. So the ABC of resuscitation plays here, airway, breathing, circulation, and subsequently we go for decontamination and find an antidote. This all should go in hand. It is not that I will take care of airway first, then I will go for breathing, then I will go for circulation. Okay. So if the patient comes, it is not that we need to stabilize. Okay. If the patient's having an unstable hemodynamics, we have to stabilize, and then you take a detailed history, have a focused clinical examination. I repeat here, do a focused clinical examination, not a lengthy examinations. Do a lab investigation appropriate, and then ask for the image. So if the patient is having a patent airway, how you know whether the patent airway is there or not? The patient is able to communicate to you, then it means that the patient is having a patent airway. Think of sensorium. If the patient is adequate, is oriented rationally, then we can proceed with the resuscitation. If the patient is having any compromised airway, you have to intubate this patient and then you proceed for the resuscitation. Okay. Even if the patient is having an altered sensorium, but the patient having a patent airway, we have to intubate. As you well know that when the GCS is less than 8, in a trauma patient, we intubate, whereas in a toxicology patient, we will keep the patient on the ventilator if GCS is less than 9. So ensure that all airway is clear and try to suck out all the secretions, and think whether the patient is having an ability to protect the aspiration. Just look for any gag reflex. Okay. And there are certain poison where you need to do an elective intubation before thinking of anything. Like a patient has taken an corrosive, acid, alkali, hair dye, glyphosate. Okay. Don't intubate in a paraquat unless the patient is literally down. Otherwise, this itself will kill the patient. Or the patient is having taken OPC and having a severe bronchoria, bradycardia, we have to intubate this patient. If the patient is having an altered sensorium, like a patient has taken a massive dose of benzodiazepine, opioids, or alcohol intoxication, then we can intubate the patient. Otherwise, we can observe this patient and try to keep the patient bed and elevation and over a period of time, the sensorium gradually improves. Hypoxia is another indication where you need to intubate, okay, and put them on a ventilator. Even certain conditions like methemoglobinemia, or the patient is having poisoning, poisoning, hydrogen sulfide, where the patient is having a cellular hypoxia, we need to do an elective intubation and put them on a ventilator. There are few conditions like toxin gas inhalation or aspiration, or the patients will come to you with a history of evening I was spraying insecticide, opposite wind has made me to inhale the insecticide. So that time we have to look for any bronchospasm, and there may be certain patients who are being hypersensitive or allergic to certain drugs can have a severe bronchospasm. So breathing, we have to ensure the patient. So here you should not confuse the patients having a patent airway, inadequate breathing, or adequate breathing with an obstructed airway. So that should be clearly categorized that the patient is having adequate breathing or inadequate breathing. And you have to monitor the saturation. If the saturation is less than 94, you have to give oxygen always by non-rebreathing mask. Okay, if the patient's oxygen is less than 90%, always try to use non-rebreathing mask so that 100% of oxygen will be given, and there will be a time for you to play. And you have to ventilate if patient is needed. And there are certain indications where we can able to know that the patient can have a pneumothorax. When the air entry is not there and the patient is having a shock, like obstructive shock, then you have to decompress the tension pneumothorax rather than putting patient on a ventilator. Circulation, you have to monitor the heart rate, rhythm, secure a large bore IV cannula. IV fluids, inotropes will be needed. Last time we had a detailed discussion about the selection of IV fluids, so I'm not going in detail. You can go ahead. So this is one of the landmark paper and written by Professor Kelly, where with whom I was there in Germany, and he is a person considered to be authoritative in OPC poisoning. So his paper, you can see that ophthalmic examination is also important in acute poisoning, and he used to see certain clues from the eye and try to tell the patient that this is the probably cause. Okay. So don't forget to examine the eye. That is a message from this paper. Physical examination, look the skin for cyanosis. Maybe any toxhemoglobinemia can be there. Pale, diaphoretic we can see in OPC poisoning, salicylate poisoning, or red or flushed we can see in TCA overdose or phenothiazines. And the patient will have a hypersalivation or dryness, a heart rate, regularity, distension. So this will give you a better clue what kind of poisoning would have been taken. Just as I already told you, just by putting a torch on the eye, we can able to diagnose whether there is a miosis is there, mydriasis is there, or any nystagmus is there. Then it will give a clue what kind of drugs have been taken in. And this is one of the recent paper. Okay, this was describing what are the things by doing a general examination we can know the poison and then outcome among the poison in Ethiopia, where it is not having a full-fledged emergency department, where they can have a resource limited area. By doing a general examination, still the beauty of clinical medicine will be expected there. Okay. I don't know how much you people have been trained. During my internship, my professor used to say that by having a smell, we can be able to identify the few poisoning, and these are the few poisoning. Okay, that will help you to say whether this patient has taken certain poisoning or not. Okay, especially the cyanide poison, you get a bitter almond. OPC, you get garlic, hydrogen sulfide, rotten eggs, and phosphine gas. This is very, very common in aluminum phosphate poisoning. We used to get a fresh Mon hair overdose. Okay. If any patient in an emergency room having any hypotension, okay, so just remember the mnemonic crash, okay, crashing. So here the patient will be having a clonidine overdose, can be calcium channel blocker, any antihypertensive overdose, antidepressant, or the patient have a sedative and hypnotics, or the patient having a opioids. So these are the various things where we can able to identify. And this is bradycardia. In bradycardia, we do a pacing. So remember by mnemonic space. So propranolol can be there, or phenylpropanamine alpha antagonist can cause, anticholinesterase drugs can cause, clonidine, ethanol, or digoxin, or Daravan, opioids can cause a bradycardia. Tachycardia, remember it is a fast. Remember free base, any cocaine or stimulant, or any amphetamine, anticholinergic, antihistamine, sympathomimetic, or theophylline. So these are the drugs which causes tachycardia. So as I already told you, whenever there is a suspicion, you are somehow the puzzle of doesn't fit into the puzzle, always think differential diagnosis as poison as one of your DD. So once you come to it, you need to know the risk assessment. So here you have to act like a Sherlock Holmes. You have to assess for the risk assessment, like a patient age, details. These are the common thing we get for putting an MLC, but we are not bothered about asking all these questions. So we need to know whether the patient has taken intentionally or unintentionally, or it is a drug overdose, or it is a drug toxicity. So this will help you to categorize what is the clue and the motive behind the poisoning. And very, very importantly, here the history is always unreliable. So we've been taught that history will give you 80% of clue. Patient will tell you the diagnosis. All are right, but in a poison, this is not true. So the patient who want to die deliberately will tell you that they would have taken 10 tablets. They will tell only one tablet I have taken. Okay, that will fool you us. Whereas they want to threat the family, they would have taken only one tablet. They will tell, I have taken 10 tablets. So history are often unreliable, okay, unless it is being clearly confirmed, evidence-based. Okay, so you have to think of initial clinical history that has to be fully correlate with your clinical finding. Then you can assess. Okay, so very, very important. You are going to deal with a poisoned patient, not just poison. That means you have to stabilize the patient first, and more important than knowing what is the type of poison. Many times we used to see the junior medical officers in the emergency room. They will call the patient to ask them to bring the poison container immediately. That can be there on the other time. We have to stabilize the patient, take care of the patient rather than this type of poison. Okay. Decontamination is a very important part. So any poison patient comes, so immediately you have to remove the contaminated cloth. Okay, there are few incidents where the patient would have not taken any poison, but they would be poured over the dress and they would be coming, and slowly the dermal absorption will be there and the patient will go for a toxic. So you have to remove all the contaminated clothing, wash the skin completely with the soap and water, and you have to do a repeated body wash. Thanks to NABH, now all the NABH assessed emergency department has to have a decontamination area where we can safely decon the patient. And while doing a decontamination, you have to pay a special attention around the ears, eyelid, inside the nostril, neck creases, armpit, groins, behind the knee, and between the toes. This where the area there will be a lot of this poison can be deposited. So you have to consider the GI decontamination as per the thing. It should be ensured if the patient is being unconscious. First, you have to protect the airway. Then you have to do a GI decontamination. Okay. So as per the American College of Clinical Toxicology, they say that within an hour you have to do a decontamination. Otherwise, you should not carry out. But it is not true in our place where if your patient wants to die, they will take a full liter of poison, they'll eat biryani and alcohol, then they will come. So we have to do a proper decontamination. So this is a lot of debate. So in that, we are not recommending the inducing the emesis, but activated charcoal, giving whole body irrigations can be considered. So IPCA is nowhere recommended. It can be used as a pre-hospital care. Now also the pre-hospital care removed the using IPCA because of lot of abuse and other things. So this is a position statement from the American Academy of Clinical Toxicologists as well as European Association of Poison Center and Clinical Toxicologists. They say that gastric lavage should be considered only patient has ingested potentially life-threatening amount of poisoning and should be done within 60 minutes of ingestion. This is not really possible in our country. If it has to happen, the patient has to sit in the emergency room and drink. Otherwise, this will not happen. So safely you can do it up to 2 hours. We can do a gastric lavage. So gastric lavage, we did initially it was done with this large Ellis tube. Now it has not been there. So if you are doing any unconscious presentation, we can do it within an hour with the Ral's tube. Tablet poisoning, having an anticholinergic, so the delayed in the gastric emptying, so we can do for 4 hours. There are certain drugs like salicylate, heavy metals, or sustained release or extended release, or the patients have taken iron, lithium, where till 12 hours we can do it. And important contraindication is you should not do it for corrosive or any comatose patient. So this kind of tube was there when I was doing my house surgeon. Now it has been removed. So what we do is putting a Ral's tube gently. We do 200 to 250 ml of water for each lavage, and then we will suck it out. Okay, and the patient has to be put in a left lateral, so to prevent the further aspiration. Corrosive, hydrocarbon, and unprotected airway, you should not do it. Or if there is any chance, there is a chance of J perforation or patient is having a recent surgery. Recently, we had a patient who had underwent a bariatric surgery and become depressed because he was not able to eat. So he has taken considerable amount of drug overdose and presented to the emergency room where we did a lavage by doing a with an endoscopic removal of the tablet, and then we saved the patient. So activated charcoal is considered to be a universal antidote initially, but not now. It is a really a black magic. Okay, the surface area of 1 gram is almost 1,000 millisquare, okay, meter squared. So it is just like 1 gram can absorb a football ground poison can be absorbed because it is very highly absorbed. Okay, so it is a carbon which is being superheated in the absence of oxygen, it becoming more activated. Okay, it is more porous. So now the multi-dose activated charcoal is being advised with the various papers are coming out, and even American College of Clinical Toxicology has been recommending to use multi-dose charcoal. So multi-dose charcoal, first we have to give a single dose, that is 1 gram per kg body weight as a slurry form. Subsequently 0.5 grams can be given, and it is based on 4th hourly or 6th hourly or 8th hourly. It depends on the poison. If the patients have taken a drug that is delaying the gastric emptying, then we can consider for 8 hours. Okay, it is very useful in the primary care. So initially we can give this activated charcoal. This helps reducing the poison load. Okay, so remember the mnemonic charcoal. So it doesn't absorb. So no more it is called as an universal antidote, but majority of drugs can be treated with this. Caustic and corrosive, you should not give charcoal. Heavy metals, you should not give. Alcohols, you should not give. Rapid onset drugs like cyanide, you should not give. Chlorine, you should not give. And others like iron, it doesn't absorb. Aliphatic hydrocarbons or petrochemical products, you should not give. And lithium, you should not give. So this will not absorb. Okay. The important adverse effect, though they say that intestinal impact, gastric distension, constipation is not all accepted, but very commonly we see is hypokalemia. So hypokalemia has to be watched when you are giving a multi-dose activated charcoal. So here there is one paper which is examining head to tail of the gastric lavage versus activated charcoal and activated charcoal alone. And they found that there is no significant difference in the reduction of systemic population with the gastric lavage and activated charcoal. Just activated charcoal is sufficient. But in our area, if it is a large overdose, we have to do a first gastric lavage and then subsequently go for an activated charcoal. Okay. So this is another paper which has been examining the gastric emptying in the self-poisoning, and they found that the patient who treated with gastric lavage had a higher rate of aspiration compared to just receiving an activated charcoal. But if you go through the subgroup analysis of this group, we see that most of the patients have been done by an unattended or not qualified person. So if it is done by a qualified person, then the complication would have been reduced. So, do the patient with aluminum phosphate require decontamination? Any guess? Do you need that? No? Okay. Then how you manage this patient early? Yes. How? This is little tricky and very commonly we see. Yes, with the potassium permanganate, good. Dialysis, no, that is different. Now the question is whether we need to do a gastric lavage or not. If yes, how we do? One, Shivani has told with the potassium permanganate. Any other? So this is a recent paper where you should not use gastric lavage, should not be done with the water. This paper says that potassium permanganate can be used as a gastric lavage where it oxidizes the phosphate into non-toxic phosphate. But it is not true in a clinical practice. So this is our paper. Okay, this we published in Indian Journal of Anesthesia, where we have seen that by using potassium permanganate, it produces lot of exothermic heat, and that produces perforation or nosocomial problem, poisoning to the treating person. So we always advise that to use vegetable oil, okay, like coconut oil or any other gingerly oil, any other oil, or nothing is available, you can use even liquid paraffin. So this goes and engulf over the poison release, and then it will help you out. Okay. So do you need to do for OPC poisoning? Yes or no? Yes. How? How you do? So the decontamination starts from your skin. Gastric emptying is there, so you can safely do and give a activated charcoal. So in Paraquat, how you do? Paraquat we do with Multani Matti, or otherwise called as Fuller's herb. Okay, these are the very three important common poison we encounter day in day practice. So we have to know this. Okay. So do you need gastric lavage is necessary for all corrosive poisoning? No. No. Yes, it's right. So we don't recommend. Okay, we see a lot of patients who have been taken acid. They used to give alkali or alkali. They used to give some milk or lemon juice like that. They used to come with egg white. Okay, some patients have been taken vinegar or orange juice. Okay, and some patients have been given with the baking soda. So they think that the acid will neutralize by alkali. This all produces exothermic heat. Okay, during the neutralization, it aggravates the injury rather than supporting the patient. So don't give anything. Okay, Cathatrix X. It is a good thing that it makes you to pass out the toxin very soon. But at the same time, there are few conditions we see that it will worsen. Okay, because of dehydration, dyselectrolynemia, all that. So unless separately, we should not give a gut decontamination. So don't give this. Initially, we used to give magnesium sulfate mixed with activated charcoal and give or sorbitol. So just it will be mixed, and then it will give a sweet kind of taste so that the patient will drink very fast. Whole bone irrigation, yes, it is been indicated only in heavy metal, sustained release medicine or body packers. Otherwise, there is no role for whole bone irrigation. Enhanced elimination, yes, starting from your forced alkaline diuresis, okay, to extracorporeal removal of thing. Now that it is very highly picking up in the intensive care unit. Even in our hospital, this is one of our patients who underwent extracorporeal treatment, and this was being done mainly on paraquat poisoning. Rat killer, we do mass therapy, and this paraquat we do multiple resin dialysis. So this can be there in the extracorporeal removal, starting from a simple hemodialysis for a toxic alcohol to a plasmapheresis for the rodenticide poison. So these are the various drugs can be removed with the CRRT or hemoperfusion or hemodialysis. So hemodialysis treatment for the poison patient in any patient who have been taken with isopropyl alcohol, salicylate, urea, theophylline, methanol, barbiturate, or patient have taken lithium, or the patient is having an ethylene glycol, then you can consider this. This can be easily remembered by a mnemonics called I stumble. Okay, so where we will use for the hemodialysis. Hemoperfusion, yes, this is another technique where a lot of biological toxins, industrial poison, and the substance abuse can be removed from this by using a charcoal hemoperfusion. CRRT is being used for the newer insecticide poisoning or the patient who are having a continuous renal replacement is indicated when there is a hemodynamically unstable. Coma cocktail, there is no role for coma cocktail. So initial our old textbooks still advise using a coma cocktail, no role for coma cocktail. So unless the CBG is not available, patient is altered sensorium, I'm not able to know whether the patient is hypoglycemic or not, then we can think of 25% dextrose. Thiamine, it is indicated only in the alcoholics. Naloxone, if you strongly suspect if there is an opioid overdose. Okay. Antidotes, yes, the antidotes are good, but antidotes is not the treatment for poisoning. Okay, there are a lot of antidotes have been updating and the newer antidotes. So in opioid overdose, American College of Clinical Cardiology, they advise to give naloxone. Okay, the naloxone is 0.4 milligram to 2 milligram. So these are the various other antidotes can be used. Like in paracetamol poisoning, you can use N-acetylcysteine, anticoagulants, rodenticide, or patient is having heparin overdose, then we can give protamine, and benzodiazepine, pure benzodiazepine, we can give flumazenil. Beta blocker overdose, we can give glucagon. Anticholinergics like atropine. P2AM, we don't advise. For past 20 years, I'm not using P2AM. Carbon monoxide, oxygen, or hyperbaric oxygen can be given. The cyanide, amyl nitrate, or sodium thiosulfate can be given. And iron, it is a desferoxamine, INH, pyridoxamine. Toxic alcohol can be ethanol, dialysis, or fomeprazole can be used. In TC overdose, bicarbazole drug. So when you are treating the patient, the basic setup, you can think of 5 Gs in the emergency room, like ABG, in the case of female, do beta HCG, CBG, ECG, and USG, and other investigations. If you possible, we can do a drug screening. Now the point of care has come. Most of the corporate hospitals are having a urine drug screening and do a chest X-ray and KUB. So then, in the once everything is been done, we can think of whether the patient can be kept on observation or ward admission or ICU or referred to some other center or can be safely discharged home. So ward admission, so very symptomatic, very mild symptomatic patient with a low fatality potential, that is 1 tablet or 2 tablet of alprazolam has been taken, nothing is there. Just we can admit him for overnight and then we can send. ICU, if the patient is unstable, potentially lethal dose, cardiotoxic drugs, anytime arrhythmias can occur, where we need a continuous cardiac monitoring, we have to do that. So these are the various criteria being suggested by European College of Intensive Care And in Indian Society of Emergency Medicine, as well as Indian Society of Critical Care, formulated this brainstorming session and made a basic guideline where the PCO2 is more than 45, need for any emergency intubation, post-injection seizures, unresponsive to the verbal stimuli, that is, patient is deteriorating in the sensorium, having a non-sinus cardiac rhythm like atrial fibrillation or some other thing, AV blocks, conductive degree thing, systolic blood pressure is less than 80, QRS duration is more than 0.12 seconds, then we can admit this patient. And very, very importantly, never discharge any patient without a psychiatric counsel. Okay, so it is very, very mandatory. So this is how we do it in primary care, and this is a handbook of poison management issued by Tamil Nadu government, and I'm one of the contributors for this national health mission. And this is a beautiful protocol which is being given by the stalwarts in this poison, and we have formulated, and this is being issued to all the primary center. So this will help you out how the protocolized approach is there, and this will help you out to treat the patient. If you want, I can share this book in the group. And very, very important. So many times the legal suit on the doctor is misdiagnosis of potential part of the poison has not been identified. I thought it is a flu. Salicylate overdose. Recently, one of my colleagues has been practicing in Gujarat, admitted a patient who had a salicylate overdose. Nobody told it is a salicylate overdose. He was admitting a patient as non-cardiogenic pulmonary edema. He was treating, and suddenly patient collapsed, intubated, and then patient was treated. Slowly, the patient deteriorated. Then they took a renal replacement. Then the patient slowly improved and extubated. After that, he told he has taken salicylate. Unfortunately, after this, the family has issued a medical legal statement that the doctor has not treated for salicylate. He treated for some other else. They didn't give any clue at all. So it is very, very important. So put one of your DD and have possibility whether the patient has been poisoned, self-poisoned, or any intentional poisoning or accidental poisoning. You have to think of it. So to sum up, never withhold intubation if the patient is in distress. Multidose activated charcoal decrease the need for atropine and the ICU stay in OPC poisoning. Supportive care is the most important measure in a poisoning patient. Don't run behind the antidote. When in doubt, always observe the patient in the emergency room. Don't send the patient home. When you are facing with an unfamiliar or a serious toxic exposure, always call a poison center or consult with a toxicologist. Thank you. Any questions? I'm happy to answer.
So there are many times patients with alcohol overdose and they are actually unconscious and or maybe altered sensorium. So how do we actually make a guess that whether they have taken some other drugs along with alcohol or not? Because there is no clear-cut history is not there, especially in our campus. Sometimes students are brought like in an altered sensorium, and then we are not sure that okay, maybe they have taken something along. We don't want them to be referred all the time because we don't do MLCs. So but there is a need to refer also because we don't know whether they have taken anything else along with it or not. Especially in the first few hours, we are not sure.
It's a very common scenario, ma'am. So most of the time, especially in the weekends, we get a lot of patients with alcohol, but the family will be suspecting, sir, today we had a cold, he went out. The patient, the person came with altered sensorium, we are suspecting poison. We don't know whether he has taken poison or only alcohol. So where the beauty of clinical medicine comes, you examine everything and think, correlate. Or you can do, if you have a ABG facility, you can see, you look for any acidosis or calculate the osmolar gap where it will give some clue. Or if you suspect there is some kind of toxic alcohol, just take the patient's urine, spin it, see under the microscope, you can see any crystals, it means that the patient has taken ethylene glycol. Okay, unless the patient's vitals are stable and you think that you have a facility to intubate and intervene the patient, you no need to refer the patient anywhere else. You can treat the patient under you.
Okay. Thank you, sir. Thank you so much.
How activated charcoal is prepared? Sir, I don't know about how it is prepared, but it is available. There are a lot of vendors are there. Even it is available in the Amazon. You can order and you can take it. RBC or serum cholinesterase, which is good predictor. Sir, actually it is a diagnostic indicator. It is not a prognostic indicator. So whichever it is available in your center, you can do it. Any other questions? Maximum dose of atropine given in OPC poisoning. It is not that maximum dose I have reached. We have to see the atropine has to given until there is a clear lung. Okay, clear and dry axilla. Yeah, the same. The endpoint of giving atropine in OPC referred after 5 days, still the patient on examination has a pinpoint pupil. Pinpoint pupil is not an indication for the atropinization, but bronchuria, definitely, yes, you should give atropine. Okay. And should we preserve the gastric fluid for medical legal purpose? Sir, no idea, sir. But still, we are not advising because there are a lot of still 5 years, 6 years before we did a lavage and sent to the forensic lab. Still, it is there, not been analyzed. So they have a lot of other work. So it is not necessary.
Sir, is it like possible to give activated charcoal in the primary healthcare setup?
Yes, definitely, ma'am. Our
Okay.
primary health, actually, I trained in Sri Lanka where we used to advise them to give activated charcoal in the ambulance or in the primary center itself. So,
Okay.
meanwhile, the travel time, the poison absorption will be reduced.
Okay, and that we have to give through the Ryle's tube, no?
Yeah, putting a Ryle's tube. So, can be if the patient is still conscious and no need to put a Ryle's tube, just mix it with some juice and then ask them to drink.
Okay, okay.
How should we manage OPC-induced polyneuropathy? Sir, if the patient is developing intermediate syndrome and if the intermediate syndrome is lasting more than 48 hours, there is a chance that the patient can develop polyneuropathy. And till now, I have seen 5 cases, out of which 2 cases still they are having a foot drop. It is very worst. So, slow physiotherapy and other supplements, it will improve slowly. There is no role for steroid. In paraquat poisoning with the progressive deterioration of SpO2, what should be the right approach? Should we start oxygen? Sir, by giving oxygen, it indicates that the patient is, you are putting the patient on a palliative care. And the progressive deterioration says that there is a fibrosis is ongoing in the lung, the patient will succumb. Yes, if the patient is having an secretions, crepitations is there, then we can give atropine for intermediate syndrome. Any other questions? If nothing, shall we end?
Yes, sir.
Thank you, sir. Thank you.
So,
Thank you very much,
so
sir. Thank you.